This is Dr. Richard Semelka. Today is Good Friday, so I thought that we would have a cheerful presentation talking about risk benefit, talking about your health and death. So don't be distracted by the light that's just above the top of my head. That's not a halo, that's a light reflection on a picture. But let's get right into it. So I've said before that a risk benefit analysis has to be informed, and the problem is that most people, and by which I mean most people, that's maybe most or all physicians, don't really have the full picture of risk benefit analysis, which in fact I don't as well, but I'll get into areas that I'm uncertain but concerned about. So what I want you to do, and it's sort of, the problem is we're talking about your health, but it's sort of, the whole thing is sort of like a game, and I've described before, it's like a 3D chess game, thinking about risk benefit. And I'll also address to this that, from earlier presentations, I've had responses asking about things like, can I get non-contrast body MRI to investigate certain things. So as we go along, I'll sort of address that. But of course, time is limited. This has to be less than 10 minutes. So it's a 3D chess game. So you also have to understand what is the viewpoint of the moderator of this game. In this case, the moderator is me. And I would say after 35 years of thinking about medicine a lot, since I've written a lot of both peer-reviewed articles and textbooks, I've been thinking a lot about medicine over all these years, and this is a number of years. I come away with the fact that overall, my viewpoint is less is more. I believe in doing less than more in healthcare, but rationally so. So you're hearing from somebody who thinks less is more. The other thing to keep in mind, that when you decide for less, you have to realize that in this game, you have a card of what is your risk for things. So I would say overall, for a healthy person, the risk of having some unknown cancer is about 1 in 100,000. So you always have in your hand, in your piece, one of the pieces is 1 in 100,000 chance for cancer or some other horrific thing. That always exists, okay? As you have more complications, that risk increases. And the famous and well-recognized complications are smoking. As you have a longer history of smoking, then the size of the piece where you have a likelihood of disease increases. Overuse of alcohol also, you increase with malignancies and other diseases. So these have to be factored in as you play the game. But the other thing to remember is baseline, there is a risk that you have something horrific, no matter what. So if you go with less than more, then you have that piece in your hand and it's just there. So that's why I also hesitate when people email me and say, well, what should I do with this and that? I tell them, this is what I would do in your situation. So you should pay attention to that, how I'm wording it. This is what I would do in your situation, somebody who knows vast about medicine. This is what I would do in your situation. Doesn't mean it's perfect. Doesn't mean I'm not going to miss that 1 in 100,000 chance, but that's the case. So that's the baseline. There are intrinsic, and that's why the more risks you have, the more you probably have to adhere to a more conservative regimen involving more imaging and more other things. That's just the way it is. And within 10 minutes, I can't really address everything except an overview. So part of the risk-benefit analysis, then, when we talk about imaging, that's my area, obviously, of expertise, is you look at the basic big imaging, MRI, CT, ultrasound, nuclear medicine. You could, include maybe PET in nuclear medicine, or if you want to break it out. So in general, if you look at the modalities themselves, fundamentally MR on its surface remains very safe, except I have a question in my mind about 7T MR systems, because what the MR is doing is it's aligning your protons both with the magnetic field and against the magnetic field. And you got to think to yourself, you know, how good is that? Turns out probably at the standard high field 1.5 and 3 Tesla doesn't seem to be, in my mind, having full knowledge in this, that there's a significant risk to it. Where the risk enters in is when you use a gadolinium contrast agent. The biggest risk that's likely to happen is either acute hypersensitivity reaction, which is true for basically every drug, and the specific risk is gadolinium deposition disease for everyone, and NSF for people fundamentally who have very advanced renal failure. So if the person who's moderating the game for you doesn't know about GDD, then there's a huge chunk of the game that's missing. Like you've taken out one bishop and maybe a rook and a few pawns. That's been taken out of the game when you're looking at the information they give you. So that's a risk, and I'll talk about more about people at greatest risk. But basically, in short, white women with a lot of with a strong history of sensitivities to drugs, multiple chemical sensitivity syndrome, and maybe some other chronic thing ongoing, some sort of toxicity, if it's long COVID or long COVID vaccine or ciprotoxicity. Any of these toxicities that have thrown off your T cells, and you have a T cell dysregulation, puts you at higher risk. So that's MR. Ultrasound on its own is the safest modality. The problem is it's not great at seeing many things. There's a lot of limitations of what it can see, and generally things in thin people, so like children, ultrasound is a good thing to start with because it's fundamentally the safest approach. Thin, small people, ultrasound does very well, and if you have somebody who's very good at doing ultrasound, it does well. Then they talk about using contrast agents with ultrasound and it's micro bubbles, and you think to yourself, well, do I want air bubbles injected into my body? Overall, probably not. CT, there's a risk of cancer with CT. We can go into that and have gone into that. We can go into more detail in the future if that's of considerable interest. There's a risk of cancer of CT from the ionizing radiation. And then the iodinated contrast used, the biggest risk is renal failure, but it also has the risk of acute hypersensitivity reaction, which can be fatal. And it's a little bit more likely than with gadolinium, but that may be a dose phenomenon that we give more contrast with iodine. Now, nuclear medicine to me is sort of a scary black box. And over the last couple of days, I was thinking that nuclear medicine should come like when you read a box of food or a cereal, whatever, it says what's in the box. When you get a nuclear medicine study, you should know what is the radiation dose that I'm getting. And if you look up online and you look on sites that major hospital centers talk about different modalities, none of them talk about really what is the dose. So the first thing that I would have to ask is I'd look at the box. I'm going to get this study. How much radiation am I getting? And again, for me, the trigger point of being very concerned with radiation is 10 millisieverts. So if I'm seeing 10 millisieverts for this study, I'm thinking, oh, wait a minute, maybe do I need this study? Well, there are indications for some of these studies, but maybe, as I said, in moderation and not as often as has been done, because basically nobody that I am aware of ever talks about radiation dose and the concern of it with nuclear medicine. So that's the ground rules for playing this game. And this is Good Friday, and of course it recognizes some sort of horrific event that happened in Christianity that made Christianity. Thank you for your attention.